Good afternoon, everyone, and welcome to Mental Health America's webinar, Defeating Isolation and Social Exclusion Through Peer Empowerment, Part 1. In today's webinar, we will be talking about Mental Health America's program called It's My Life, Social Explorations, as a way to address isolation and social exclusion in your community. By the end of today's webinar, you will learn about the program's foundational principles, understand the program structure, process, and outcome measurements, as well as learn about the training Mental Health America now offers to organizations who desire to implement our program. Mental Health America is the nation's oldest advocacy organization addressing the full spectrum of mental health and substance use conditions and the profound impact they have on public society and public health. Mental Health America was established in 1909 by Clifford Beers, who was himself a mental health peer. We focus on prevention for all, early identification, and intervention for those at risk, integrated health, and behavioral health care for those who need it, with recovery as the ultimate goal. The national headquarters for MHA successfully launched the It's My Life Social Explorations program in the Northern Virginia area. The purpose for It's My Life is to advance recovery and improve the lives of individuals with severe psychiatric conditions, with a focus on some of the most isolated, misunderstood members of our communities. We assist peers in finding their power to reclaim their place in the community and provide a safe place for individuals to learn and practice these skills to prepare themselves as they move forward in their chosen path of recovery. Participants are accompanied on their recovery journeys by trained life coaches who help them to bridge the gap to a larger social world. Social connection fits into the overall goal and journey of recovery. The importance of the It's My Life program is that it's designed to help build networks of friends and intimate relationships to create that strong social support system that is so imperative to recovery, to social functioning, and increasing self-esteem and self-worth. Ultimately, our program uses the self-directed care model and other principles to help the participants to set and reach their own personal and social goals that might include going back to school, finding a volunteer position, or competitive employment. Some of our participants also specifically concentrated on making friends outside of the mental health community. They stated that this was important because it helped them to turn their focus off of their illness and put it more on what they felt was more positive in their lives. The piloting of our program focused on individuals with schizophrenia and schizoaffective disorder, and this was because they're often among the most isolated and marginalized of our communities. Social functioning impairments seem to be evident at all stages of these illnesses, and data shows that these difficulties may often predate any signs of illness, sometimes by many years. So the impairments and social functioning social functionings that influence the lives of people with schizophrenia are captured in a simple observation, and that is that the majority of people with this disorder do not marry. Compared to the general population, people with schizophrenia are more than 6 times more likely to remain unmarried. A little bit about schizophrenia. Schizophrenia affects how the person thinks, feels, and acts. Someone with schizophrenia might experience difficulty distinguishing what is real from what is imaginary. They may be unresponsive or withdrawn and may have a hard time expressing what's considered normal emotions in social situations. Similarly, people with schizophrenia have the same troubles often, but may be accompanied by a mood disorder such as depression or bipolar disorder. Given the complexity of these conditions and that social functioning impairments occur at all stages of the illness, the need for innovative approaches in helping to develop social skills, friends, and intimate relationships is particularly acute for people with schizophrenia. Although the piloting of this program focused on individuals who had schizophrenia or schizoaffective disorder, it's important to note that the principles and practices of social self-directed care can be applied with any mental health diagnosis. It's My Life is quite a unique program. There are many programs out there that attempt to provide people with social skills training, but many of them have limited success in really connecting people to friends and to community. The It's My Life program is designed to fill that gap that exists in current systems or treatment as usual. Traditional approaches such as medication, hospitalization, and dynamic psychotherapy have had limited effectiveness when applied to socialization and work aspects of individuals who have psychiatric disabilities. So It's My Life provides a one-on-one skill support and emphasizes that self-direction is not just for those who are considered to be doing well. What you'll see here is a mock flyer of some of the things that are often done in the communities, like at our local community mental health centers. They may have social events like spaghetti night or bingo games or other types of gatherings or barbecues, things of that nature. And what we find is that people might come to those events and they'll socialize for the time of that event, but not really build lasting connections with other people. And so once the event is over, everyone disperses, and there really isn't a life change that has really taken place from these particular types of social events. And so It's My Life is unique in the way that it approaches it so that people can build those lasting relationships that carry on beyond just a one-time event. Through social self-directed care, It's My Life uniquely provides opportunities to practice newly learned skills in a safe and non-judgmental environment with feedback from their life coach. Recipients of services have the chance to determine the skills that they feel are important to them. And we also provide the financial support to participate in activities that people may otherwise not be able to afford. And that included transportation. Creative ways to increase self-esteem and self-worth, improving overall functioning with networks that include supportive and sustainable relationships that increase the overall quality of life. That's something else that It's My Life uniquely provides. I'm going to do an overview of the process of the It's My Life program. Start with the life coach training, recruitment, forming partnership, skill building, followed by outings, understanding our evaluation techniques, and most importantly, the results. So in our program, there are several roles. First is the program director, whose duties include providing supervision for the peer life coach team. Supervision also includes issues of job clarification, performance, confidentiality, disclosure, working with other staff, especially those who may not be familiar or comfortable working in settings with people who identify as mental health peers, boundary issues, and other issues as they arise. The program director provides support for the peer life coaches. Having appropriate support available is critical in peer support in any variety. And approving the participants' monthly spending plans is something else that our program director does. This includes verifying that the social goals chosen by the participant assure that they match up with the action plan and the spending plan and relate directly to the accepted social goals. Next on our staff, we have the peer life coach. And the roles of the life coach include assisting participants in assessing what their goals are, completing their monthly social budget and action planning, and helping them to make sure that the goals that they're choosing relates to the budget that they're creating, and helping them to explore possibilities for broadening their social horizons. Life coaches also help conducting exercises to facilitate the accomplishment of those goals and the various skills that strengthen the participants' interaction with themselves and with others. They serve as a role model of recovery and positive social interaction while accompanying participants to social activities. As time goes by, the coaches begin to gradually pull away, and that puts more responsibility on the participant. So it comes to a point where they no longer need their life coach, and they become more independent in their social activities. And that's the ultimate goal. So a life coach also encourages participants to socialize with others, and the coach helps maintain those current friendships and gain new friendships as well through various resources. Our peer life coaches provide assistance and new social life skills in several different areas. They include, but certainly are not limited to, helping participants with identifying areas of interest. For those who have been isolated for so long or socially excluded for long periods of time, may not have developed an idea of what they like to do, what they enjoy, or what they might like to try. And so it's important for our life coaches to have access to those kinds of resources in the community and information about what's available. We also collaborate in decision-making with the participant, budgeting the spending account and attending social activities, assisting in building community inclusion, helping form and enhance healthy relationships and intimate relationships, coaching and feedback regarding progress, which is very essential, and building connections to employment and volunteerism if that is what the participant desires. And then, of course, last but not least, we have the participant. There are some basic requirements for eligibility for individuals to become participants in the It's My Life program. First, the need for services is determined by completion of the personal outcome measures interview. We will cover this a little bit later on. Next, they must be at least 18 years of age. That was for our pilot program. The program is adaptable to other age ranges, but may provide a bit more of a challenge in training younger coaches and having them understand the principles of the program of peer support, psychiatric rehabilitation, and some of our other tools. So it is adaptable to a younger audience, but just be aware that it may present additional challenges to be cognizant of. Participants must be competent and able to give informed consent. If your participants are minors, then that would change according to regulations and legislation in your area. And able to manage personal finances, establish goals, and action plans. And they must be willing to adhere to all agreed upon participant responsibilities. Those responsibilities were the completion of the POM interviews, regular meetings with their life coach, generally that was weekly or every other week, weekly completion of the guided journal, and proper use and reporting of the social spending budget they received each month. So now we're going to look at the Peer Life Coach training. Peer Life Coach training includes the following things: peer support, self-directed care, psychiatric rehabilitation, life coaching, and motivational interviewing. Our coaches for our pilot program here at MHA were trained on these individual techniques, and what we are now offering is to teach your coaches the specific parts of these techniques that they will need to apply the principles of It's My Life. Peer support we define as including the sharing of experiential knowledge and skills and social learning, plays a invaluable role in recovery. Peers encourage and engage other peers in recovery and provide each other with a sense of belonging, supportive relationships, valuing roles, and community. The core components of peer support we identified as privacy and confidentiality, ethics and boundaries, mutuality, shared decision-making, and effective listening. As peers, life coaches build trust. We understand because we've been there. There is equality in the relationship. Information and experiences are freely exchanged, and that way both parties benefit from each other's strengths and hope. Another technique that we used was the practice of self-directed care. Self-directed care provides an opportunity for individuals living with a psychiatric condition to assess their own needs, to determine how and by whom those needs should be met, and manage the funds to purchase those services. In self-directed care, the funds follow the person. Self-directed care programs hinge on the belief that individuals are capable of choosing services and making purchases that will help them begin or to remain on the road to recovery and to develop or regain a meaningful, productive life. Social self-directed care originated as the Cash and Counseling program. The core components of self-directed care are self-determination, civil and human rights, personal agency, individual responsibility, and dignity of risk. Incorporating self-directed care into the Into My Life program meant that each participant was able to select their own life coach. So before they actually got active in the program, they met with each of the available coaches on the team and were able to read their bios, ask them questions, get to know a little bit about them, and then choose the person that they wanted to work with, who they felt they could connect to most. Each participant also determined their own goals, identified which skills were most important to them, established their own person-centered action plan, create and control their social budget with the guidance of their coach, and determine the location for meetings with their coach. So if a person was more comfortable meeting in their home, their life coach would go and meet with them at their home. Some people chose to meet at the library. Some chose to meet at the local coffee shop. So the possibilities were just out there for a person to be most comfortable, choose the setting they were most comfortable in. Psychiatric rehabilitation. A person-centered and strength-based approach to help individuals with persistent and serious psychiatric disorders to develop the emotional, social, and intellectual skills needed to live, learn, and work in the community with the least amount of professional support and increase their capacity to be successful and satisfied in the environments of their choice. The core components of psychiatric rehabilitation emphasizes that recovery is possible and highly probable, person-centered, strengths-based, and uses the recovery model versus the medical model. Our life coaches took an online course with Boston University Psychiatric Rehabilitation to learn the different components of psych rehab and are now able to apply them with peer support and our other techniques. And we will now teach that to your life coaches. Additionally, we incorporated professional life coaching in our training. Life coaching is described as partnering with clients in a thought-provoking and creative process that inspires them to maximize their potential. This process helps people dramatically improve their outlook on the future while improving their leadership skills and unlocking their potential. Core components of life coaching to guide participants to discover their own answers, help identify challenges and work in partnership with them to turn those challenges into victories, to challenge thought or behavior patterns, providing accountability, helping participants find their power, intensive goal setting, and action planning. We also use motivational interviewing, a person-centered, goal-oriented approach for facilitating change through exploring and resolving ambivalence. an engaging and collaborative conversation style for strengthening a person's own motivation and commitment to change. The main goals in motivational interviewing is that our participants are able to make choices that are fully informed, deeply thought out, and internally motivated. The framework for motivational interviewing is provided by the stages of change, with exception and the compassion at the heart of it. Conversation for motivational interviewing includes moving from status quo talk to change talk, which is twofold and uses the acronym DARN CAT. Part 1 is preparatory: desire, ability, reasons, and need. And so our life coaches explore these things with our participants to see where they are in that process. And then part 2 is mobilizing, where there's commitment, activation, and taking steps. Next part in It's My Life's process is recruitment. We reached out to local behavioral health care centers, drop-in centers, clubhouses, community centers, libraries, and anywhere else that peers are found. You will see a sample of a type of flyer that we used or that you might use when you implement the It's My Life program. We were mindful, of course, of our eligibility requirements for participation and tried to reach out in areas where we might find people who would meet that criteria. Then comes forming the partnership. First part of forming the partnership is just getting acquainted. The coaches' bios are shared with the potential participant in advance, if at all possible. Participants, as I said, meet with all of the available coaches to determine their level of peerness. And then they select their own coach. And of course, trust and solidarity are built through strategic self-disclosure, empathy, honesty, and authenticity as time goes by. The life coach also explains the program to the participant to make sure that they have a full understanding of the different parts of it. So that includes that participation is voluntary, understanding of confidentiality and the HIPAA regulations, professional boundaries, the structure of the visits with life coach, appropriate use of their $60 social stipend and requirements for keeping receipts, as well as the phasing out process. I'd like to note here that there was a $60 social stipend that we gave to our participants on a monthly basis. There were 2 requirements for them being able to get that $60. One was to maintain receipts for keeping receipts for their spending, and also that the spending had to be according to their social goals, and then that they continued to do their weekly journaling. We chose the amount of $60 because we learned that that was the maximum a person could receive without impacting other benefits that they were receiving, such as Social Security or disability income. So again, they received a monthly allowance of $60 to be spent on advancing towards the 3 goals that were set with the assistance of their life coach. And that was pending the guided journals and providing the receipts on how this money was spent, and the correlation to the social goals. And as previously stated, the activities are pre-approved by the life coach and the program director. Of course, there was flexibility if an event got canceled or they were taking public transportation and the weather was bad. Just different things, working with people very individually throughout the program on an as-needed basis with flexibility, but just having a basic overall understanding of how things work generally. Participants receive their handbook at their first meeting, and that includes everything they will need for the program. There's the enrollment agreement, the guided journal, various forms, and worksheets and handouts, although those may be distributed throughout the program, throughout their enrollment as we discover things that are more relevant to them. Also, during the forming of the partnership is the goal setting process. Together, the participant and the coach evaluate the participant's feelings about their current social standing. They assess hobbies, interests, and community involvement and their accessibility to them, action planning and impact, and create the monthly social spending plan. The next important part in our process was skill building. The skills included communication, emotion regulation, effective listening, self-care, personal boundaries, and various other skills as they are discovered and the participant feels that they are necessary to improve their positive social interactions. Then there were the outings, which is actually my favorite part. Some examples of the outings that some of our participants went on was the accompaniment of their life coach, and then eventually just kind of in the setting with their own friends that they had made, were monuments and museums, art classes. I think a couple of people did swimming classes, theater, meetup groups, bowling, peer support groups, baking classes, and my personal favorite was the circus. We actually also did a gathering with all of the participants in the group. We sent out an invitation to all of the ladies that were in our group, in our program, because they had connected with their life coaches and said, I want to know what the other participants are doing. I'd like to get some ideas from them. And so we at MHA sponsored a get-together for everyone. We did 3 different ones. They got together, played some games, socialized, just to kind of have an opportunity to exchange ideas with each other and kind of get to know each other, since they already knew they had a commonality. And during that time, 3 of the ladies had a conversation with each other and discovered that they all liked the circus and were interested in going to the circus. So we all packed in my teeny little car, and we spent the day at the circus, and it was amazing to watch these ladies who had never met each other before and didn't even have the same life coach, but made that connection, coordinated things with my assistants, and we went out and had a great time. So the structure of the outings as related to our program is that things start out with the participant and the coach. So the coach accompanies participants to events or activities and initially provides transportation if needed. This, of course, would be according to your agency's policies. As things move forward, the participant goes out with the coach and a friend. So the coach serves as a role model of recovery and positive social interaction. The coach might even take the participant to stores to obtain needed materials for upcoming social events or activities. And then the final stage is where the participant and the friend are just together without the coach being there. The participant applies their acquired skills from the program to become more independent in social interactions, thereby reducing their need for the coach, and the coach gradually begins to pull away, just availing themselves for support as needed. An illustration of this, there was a woman who loved the ballet but had not been in years and years. So she and I got together and went to the Kennedy Center, and it was just a beautiful experience. Later on, we just started talking a little bit more. She said she wanted to go back to the ballet. And there, as her coach, I was tasked with challenging her to make it more than just an outing between she and I. And so she invited a friend from her church, and we all went out together to see the Nutcracker that holiday season. We went to a restaurant before. We just stopped at McDonald's. We all got a little bit to eat and then walked over to the Kennedy Center for the ballet. Just wonderful conversation on the way there and on the way back. Really just enjoyed the show and enjoyed the outing. The most amazing thing that I found with this experience is it turned out that we all were actually mutual friends. And it was quite a surprise to me. But just to see them interacting with or without me was a beautiful thing, to see this participant as she progressed to be able to do things on her own, to where now she will just take a friend, jump on the bus, and go on over to the Kennedy Center and watch the free 6 o'clock show. A key part to the outings is keeping the participant engaged. Ensuring ongoing growth is essential to that engagement. As participants learn new skills, their coach challenges them first to practice with the coach and eventually be able to use them on their own in a social setting. So person-centered activities really was what encouraged the social interaction. So I shared a little bit about our day at the circus. One of our other participants also decided to go out to the Spy Museum. And there you can actually see a photo of myself and the ladies at the Nutcracker Ballet. Next is the evaluation techniques. These are the things that we use to measure the success of our program. Personal outcome measures. It's a tool to measure the quality of life. We refer to it as the POMs. Personal starts with a person's own view of their life. The outcome defines what is important to the person, and measures offers objective determination of whether people are getting what is personally important to them. So instead of looking at the quality of how services are being delivered, POMs look at whether the services and supports are having the desired results or outcomes that matter to the person. And essentially, that's what matters to us. Personal outcome measures was developed by the Council for Quality and Leadership. There are 21 quality of life indicators in the POM survey. For the purposes of the It's My Life program, we focused on 13 of those 21 indicators. We conducted the personal outcome measures survey or interview with each participant at least 3 times. And that was one, to determine their eligibility. Sometimes a person might actually be doing too well socially to need the program. And so to make sure that we were really providing assistance in an area that it was needed, we used the POM survey to really look at that and determine their eligibility to make sure that it was a needed service and that the person actually had room to grow significantly. We did a midpoint progress check with the POM tool, and then again the closing assessment to measure where they started to where they ended with our program. Our next evaluation technique was the guided journals. In addition to a summary of their week, the journal had probing questions that are intended to get at how their social interactions and the skills they're learning are helping participants and any other potential issues they might be having with themselves or with the program. From the journal, it can be determined if the program has an effect on someone's overall well-being. Next, we have satisfaction surveys. It provided participants a way to anonymously provide feedback about the program and about their coaches. So we mailed them out to all of our participants and included the business reply envelope that has postage paid with their survey, so they could return it to us without having to worry about that part. They were completed in the middle of the program as well as at the end of the program. And this was a way to get feedback for our coaches to let us know areas that we could improve in and how we could better assist our participants. We also measured hospitalization rates. This was the only clinical aspect of our program aside from the diagnoses. We removed all clinical language and processes from our program. So we specified the diagnosis just to make sure that we were working with the most challenged population. And if we knew that if we could work with the most challenged population, then we would definitely be able to help those who might be less challenged. So if we start with the hardest way to go, then we figured that things would be easier as symptoms were less intense or challenges were less intense. So we really wanted to focus on those with the most difficulty, as people with schizophrenia or schizoaffective disorder typically have with social impairment. And then the hospitalization rates were measured as well. So the past hospitalization from the 2 years prior to enrolling in the program were documented with informed consent provided by each participant. Any rehospitalizations that occurred during their participation was also documented. And we also took note of any changes in services that the participants received while enrolled. Last is the results of our program. So for our POMs, these are the statements that we focus on, the quality of life measures that we really took a look at for our participants. And you'll see the initial score there of where things started. Many things started out pretty low. Some were even at 0%, and none of our participants described their quality of life as including those factors. Those two were participating in the life of the community and having friends. We actually had 0% of our participants identify that as a part of their lives. And so you'll see there's actually one that decreased. And the one that decreased was that people choose personal goals. And we asked ourselves how that would decrease. We couldn't really understand why that would decrease. Our program was all about choosing their personal goals. It was all self-directed. It was all about what they wanted and doing it their way. So we inquired of our participants to figure out what happened there. And according to them, setting their own goals in this program made them realize how many other goals were being set for them. They were now able to recognize what it looks like and feels like to set their own goals and recognize when that actually wasn't happening. Here you'll see a graph that more visually illustrates the changes from our baseline scores to our final outcome scores. The results from our guided journals. From the entries, it was observed that the participants' chosen activities often seem to increase their overall self-confidence. Since people with serious mental health conditions often will not voluntarily involve themselves in a new hobby or social situation, this program assists them in going outside of their comfort zone to become more connected to the outside world. When they realize that they're more than capable of learning new skills and responding appropriately to social stimuli, they have a boost in self-confidence. Sometimes just the idea of being able to go out and do new things seemed to boost people's mood. And they were just more lighthearted and conversational and open when they just kind of explored new possibilities for themselves. As a direct result of participants being in control of their program and actively improving their social networks has been that they're learning about themselves, which in turn provides them the opportunity to better themselves. So, an example, one participant went out to restaurants with different friends each week of her journaling. Each week she would write about what she enjoyed and what she would like to do differently the next time. As the journals progressed, it became evident that she was learning from her mistakes and becoming much more comfortable engaging in appropriate restaurant conversation. By about the 10th week of journaling, here's what she wrote. I was able to have a free-flowing conversation that was effortless and was able to relax and enjoy myself. And that is the ideal experience for anyone to have when they're out in a social outing, when they're out with friends or family or just out in their community, that they really just get to enjoy themselves. Results for our hospitalization rates. In the 2 years prior to entering the social self-directed care program, participants had experienced a total of 15 hospitalizations. In the 19 months of activities, only one member had experienced a single hospitalization. And aside from joining the It's My Life program, our participants had no other changes in the services they were receiving. So we can attribute these changes, this success, this decrease in hospitalization to connection, to being out with other people. One participant who shared with me that she had spent the last 10 Christmases in the hospital. Every Christmas for the past 10 years, she was hospitalized. And that year in the program, she did not go into the hospital. And I asked her to journal about it, asked her to journal about her experience and what she thought was the difference. And she said to me the difference was that she had somewhere to go. She had people to be with for Christmas. She didn't feel like she needed to be in the hospital. And it was more of a priority for her to stay out because she had other plans. And so really it was just having that source for her, that resource, as a result of her networking and being involved in the community, that she wasn't isolated and alone, which she said exacerbated her depression. The results for our satisfaction surveys. Of the 17 participants who completed and returned our surveys, 95% rated their satisfaction with the program with the highest possible rating. And this is really a report card for our life coaches to know our areas that needed improvement, as well as the areas that we were doing well in and wanted to maintain that. So again, you can see the overview of how the process works, starting from the life coach training, which we now provide, going to recruitment, forming the partnership between the life coach and the participant, skill building, the outings, our evaluation techniques, and our results. So I'd like to share with you some insights from the It's My Life team from our pilot project. One of our life coaches shared, she observed this: loneliness and social exclusion destroy health and happiness. Research has shown that the lack of connectedness to friends and community worsens psychiatric problems and leads to chronic illness and early mortality. And surveys conducted with people living with severe psychiatric disorders, asking what factors contributed most to their recovery, the number one answer is some variation on having at least one person who believes in me, having at least one friend. And I remember our program director, Patrick, sharing that with me when we first got started with this program. Another insight shared was that the It's My Life is innovative, fun, and supportive, an effective tool for building relationships in the community and discovering meaningful and productive activities. Additional insights were that self-directed care is essentially individual-based. It was interesting to find that participants often inquired what others were doing in the program and requested group activities. In response, we held 3 gatherings in the community and invited all program participants. And that's similar to the event that I shared with you about the ladies communicating about their interest in the circus. And the 4th gathering that we had with all of our participants was actually organized and hosted by one of the participants. An amazing evidence of the growth that we saw in the ladies there. And all the participants have in some way maintained or improved upon the growth they have achieved while in the program. One has actually become a peer support specialist. Several have returned to work or school, and others continue to set and pursue personal goals involving their recovery. One of our life coaches commented, she said working with one person was particularly really hard. She wasn't getting any other services. Our coach says, I took her to ESL classes and got her hooked up with a gym, but she really needed more help than what I could give her. She was living in such poverty, and I remember she didn't even have her own bed to sleep in. The financial support from the program was life-changing for her. And that's the case for a lot of our participants. And this is an example of where the program director would be essential in providing support for the life coach. Just that feeling of sometimes powerless that comes from not being able to do as much as you'd like to. And that was a common experience amongst our life coaches. And the support of our program director was really critical in dealing with those kinds of situations. Our coach shared, what I gained was knowing some really interesting people. I became friends with some of them. It was gratifying to see all of our people grow and change. I saw the success in their eyes when they reached some of their goals. And the words of our program participants. These are some quotes specifically from their journals or surveys that they returned to us, or just during their PLM interviews that they shared. One woman wrote, she says, I was deprived of the opportunity to eat in restaurants for almost 13 years. So this program is like a revival to me. Another woman wrote, this was a really nice program. I enjoyed the money to buy beads to make jewelry for my friend. It is nice to have money to spend on my friends. This program has a positive impact on my life. It gives me hope. This is one of the best things that has happened to me. I will continue to move forward. Other participants wrote, Confucius said, I do, therefore I understand. This was a program of doing and understanding. I have learned about small talk and am now a bit more assertive. Another woman says, I am more confident to speak with people that I don't know. I'll introduce myself and talk with them. I used to wait for people to come to me. Now I start the conversation. Mental Health America's vision for the future of social self-directed care as a part of recovery is to see the It's My Life program implemented across the country. The program effectively addresses the needs that each of us has to build friendships and connections to our communities, and self-direction empowers us to take control of our destinies. Social inclusion is about being able to participate and contribute to social life in economic, social, psychological, and political terms. To do this requires having personal capacity as well as access to a range of social roles. You can implement the It's My Life program in your community. The It's My Life program is suitable to be operated by peer-run organizations, state mental health establishments, community services boards, or mental health centers, church organizations, Mental Health America affiliates, NAMI groups, and many others. In order to get started, you will need the following: fidelity to all the basic principles of the It's My Life model, especially remaining truly self-directed. Attending MHA's 3-part training webinar. This is part 1. Parts 2 and 3 are coming up. The It's My Life training manual, participant handbook, and handouts. Those things are all available for download on our website, and hard copies will also be sent to those who participate in the training that we offer. So you will also need peer support specialists to staff as your life coaches. You will need a program director to oversee the program, community resources. That's just being aware of what's available in your locality. And funding, of course. Possible sources could include state mental health authorities, philanthropic organizations, mental health centers, private donors, any other ways that you could foresee achieving funding. There are really endless possibilities. In regards to the funding, our pilot program was funded by Mental Health America, the national organization, and also by a grant from Jensen. Funds were used for paying the salaries for the program staff. Some organizations might opt to use volunteers. That is definitely a possibility. Training of our coaches, especially the online course that we took from Boston University on psychiatric rehabilitation. Program materials, the social budget for participants, and that would be the $60 a month stipend. Reimbursement for coaches for cost of travel and outings with the participants. So Mental Health America's experienced peer life coaches are available for individual or group training in person, by phone, or by video conference. Mental Health America would like to thank Jensen and Outings for providing the grants to train organizations to end social exclusion and isolation through the It's My Life social self-directed care. Thanks to their support, we are able to offer this training for free. All of our virtual trainings are for free. We also offer in-person training at a reasonable cost to cover the expense of the life coach's travel. This concludes our part 1 of Defeating Isolation and Social Exclusion Through Peer Empowerment webinar. Part 2 of this series will take place at 2 p.m. on December 9th. That's 2 p.m. Eastern Time, 11 a.m. Pacific. Please know that the recording of this webinar will be available on our website, mentalhealthamerica.net. The recording will be available for your review as well as the slides for download. If you have any questions, please do reach out to me here at Mental Health America. I can be reached by phone at 703-946-0529. My email address is scarpenter, that's SCARPENTER @mentalhealthamerica.net. Thank you again so much for joining us. If you are interested in implementing the It's My Life program or simply getting more information, please do reach out to me. I would be happy to discuss it with you, to offer additional material or information, and even to share with your leadership team. My number again is 703-946-0529. Email address scarpenter@mentalhealthamerica.net. Thank you so much for joining us, and we look forward to seeing you in part 2, Defeating Isolation and Social Exclusion Through Peer Empowerment. Don't miss the Empowering Opportunity, part 2.